and when you choose to test a person for an underlying genetic cause of their epilepsy. One of the biggest questions I get when somebody receives a report for epilepsy genetic testing is, what do I do with the variants of uncertain or unknown significance? So I'll walk you through an approach to a VUS. And I'll also briefly touch upon personalized medicine in genetic epilepsy. But really, I want to kind of bring it into the field of education. So genetic epilepsy, is kind of a really interesting field of research, but I'm trying to promote this idea that it's now becoming a mainstream in our clinical practice, both in pediatrics and in adult epilepsy. So most people here, I think, know what epilepsy is. It's a tendency to recurrent unprovoked seizures. It affects many people. 1 in 100 people are affected by epilepsy at this time. And we know that about 30% of these patients cannot achieve seizure control despite adequate prescription of anti-seizure medications. And epilepsy can be genetic. So we know that if we exclude acquired causes of epilepsy, such as brain injuries, tumors, strokes, infections, or autoimmune encephalitis, depending on the studies you read, about 30 to 40% of epilepsy has an underlying genetic etiology, and we can identify single pathogenic genes in between 15 to 50%, depending on the age of the patient and the phenotype of epilepsy. And so every couple of years, I like to look in how many genes have been discovered. And in 2022, there are about 927 genes for epilepsy identified. So as you can see, there's always an exponential increase in our knowledge every year that goes by in the area of epilepsy genetics. What's kind of interesting is that the top, I've actually put 12 genes here, but about the top 11 genes or so can account for about 74% of the variants in epilepsy genetics, which is interesting because most of us look at this gene list and we've recognized these genes in our patients. So even though there are many genes potentially causing epilepsy, there's really a top 10 list that are the most likely underlying etiology. So when should you consider epilepsy genetic testing in your patient? So if they come into you and they have a couple first-degree family members who have the same phenotype, or if there's a suspicious phenotype. So for example, in FFEVF, or familial focal epilepsy with variable foci, patients can have epilepsy, but they can also have psychosis or sleep disorders. So if you see this family that's rich in epilepsy, but also other aspects of the phenotype, that should make you think, maybe I should test this person for an underlying genetic cause. If they come in with what I consider as epilepsy plus, so epilepsy plus intellectual disability or autism, or developmental and epileptic encephalopathy, or if they have a cognitive or developmental regression, if they have syndromic features or multiple organ systems affected, or if they have associated paroxysmal neurological features, such as kinesiogenic dyskinesias, hemiplegic migraines, episodic ataxia, etc. If they have refractory, atypical, or progressive generalized epilepsy, or if they have atypical, refractory, or progressive focal epilepsy. In Canada, our guidelines used to recommend against genetic testing in patients with focal cortical dysplasias. We now know that many of them can also be genetic. So we would encourage you to consider epilepsy genetic testing in that case as well. Or if you identify a clear epilepsy genetic syndrome that is associated with an underlying genetic cause. When is genetic testing for epilepsy not indicated? When there's a clear acquired cause demonstrated typically on history, but also on imaging. So for example, if the patient presents and there's a known history of perinatal ischemia and their imaging reflects that, there's likely no need for epilepsy genetic testing. Or if a person comes in with explosive new onset epilepsy with associated features, but you identify autoimmune or paraneoplastic antibodies in the CSF and or serum, genetic testing is not indicated. Again, I put a little star by FCD because, of course, we now would recommend patients with FCD be tested for genetic causes. I will mention that it also has to match the phenotype, right? So I had a patient in my own practice with a very small right parietal infarct, but they had a severe developmental and epileptic encephalopathy, were not mobile, had severe epilepsy, and it just didn't make sense with this small lesion. It turned out they had an underlying STXBP1 pathogenic variant. So it has to fit the phenotype, right? That acquired cause. So why would you want to order genetic testing? So yeah, it's interesting. You get a result. Why does it really matter? So we know that many forms of underlying genetic epilepsy can inform long-term prognosis. We can either counsel patients that, yes, this is a progressive epilepsy. Perhaps it can even lead to death or severe disability. And sometimes we can say, well, actually, it's not a progressive epilepsy. We can also counsel families. So especially the parents of a child who's affected, what is the risk of another child being affected? We can test at-risk family members. And there's also a catharsis, a psychosocial benefit for families. So perhaps a parent, perhaps the mother blames themselves for something that they did during pregnancy when they find out actually it was a de novo variant that causes epilepsy, an accident or a change in the gene that happened, at the moment of conception or shortly thereafter, that the parent had no effect on, that it was just a random change that was not the cause of the parent's fault. And also, we now know that the more we know about the underlying etiology of the epilepsy, the more management strategies we can offer. And we call this precision therapy in epilepsy. So you need to have a bit of a crash course in genetic counseling for the neurologist. Obviously, we're not genetic counselors, we're not medical geneticists. We have to know how to advise patients when we offer this testing. So obviously, consent's important. Most of the time, we can get that pretty readily from the patient or the family. But all of us have patients who, are no longer in contact with their families. So often they have a power of attorney that's been provided by the province. So we have to reach out to that person. We also have to recognize that at least in my province, Ontario, and many other provinces in Canada, we don't offer whole exome sequencing. We focus on typically the gene panel or CGH microarray. So we have to say we're testing for epilepsy genes specifically and not other genes such as for cancer, cardiac disease, etc. We're also not assessing for paternity in our testing. We also have to counsel that, yes, sometimes we get a positive result. We know this is the cause. Sometimes we get a negative result. And that doesn't mean that the epilepsy is not genetic. It just means that we haven't tested for the right gene, or the right gene hasn't been identified yet. We also can get the middle of the road, the kind of frustrating variant of uncertain significance, which is a change in the gene that we don't know whether it's responsible for an underlying disease or not, whether it actually changes the function of a protein. Also a reminder that the Canadian Genetics Non-Discrimination Act suggests that an insurance company cannot request genetic testing results from a patient to inform their insurance. And I have a close relationship with my colleagues in medical genetics, and I have a low bar to refer to them, to ask their advice and to counsel and to get their counsel on a patient. So just remembering that patients with multiple organ systems affected, or if there's a strong family history and a gene is identified, I often refer to medical genetics for these patients. Advantages. Prognosis, right? So we can inform patients on, we think this is how the disease course will follow. We also now know that genetic epilepsy testing can inform epilepsy surgery. For example, genes identified in the mTOR pathway tend to do well with surgery, whereas say SCN1A variants don't. So we can inform patients on that as well. We can get familial testing and closure, and often alleviation of guilt, as I mentioned before. And again, precision therapy possibilities. That being said, sometimes there's negative consequences as well. There's more uncertainty. We identify VUSs, and so we have to keep reassessing these variants. Sometimes there's a loss of hope or parental guilt because we identify a pathogenic variant in the patient, perhaps that has been inherited from the parent, even though it was a non-penetrant gene. So there's a sense of guilt in the parent. So available genetic testing, most of you are probably aware of this. So a karyotype is when you kind of take a bird's eye view and look at the genes that a patient has, and if there's any breakages or changes in the conformation of the gene, which can contribute to epilepsy. Often in my practice, these patients have been diagnosed in childhood because they often have multiple organ systems affected. So they're tested early on. There's also a CMA or CGH microarray, which looks for small segments of the chromosome that have been duplicated or deleted, and that can contribute to epilepsy as well. We know that, for example, a CMA can really yield about, depending on the studies you read, between 10 and 16% can have a yield, especially in patients with intellectual disability and or autism with epilepsy. And especially if it's generalized epilepsy, about a third of patients can have an underlying copy number variant as a cause of their epilepsy. We can also do single gene testing. I have to admit, I very rarely do this. I kind of feel like, either the panel or the whole exome is kind of the Costco variant. You get more bang for your buck if you test more genes. Most underlying syndromes have either one gene causes many syndromes or one syndrome is caused by many genes. So really a single gene is you're really betting a lot on that one gene, unless there's a family member who's already affected and you're pretty confident that's your gene. Or there's a specific genetic test you're looking for that's a little bit different. So for example, for dodecamer repeats in cystatin B, you're doing a slightly different test for that particular gene. I mentioned mitochondrial, and this is the only time I'm going to mention it. If the phenotype fits, it's a completely separate set of genetic testing that you're doing, but be mindful if someone fits that phenotype that the gene panel and CMA may be completely negative if they're in the mitochondrial group. So I'm most likely to order a CMA and an epilepsy gene panel. And depending on which panels you order, they range from 100 to over 400 genes. And depending on the cost varies quite a bit. Often many companies will do what we call a panel on an exome backbone. They're actually testing all of the exons in the test, but they're only reporting the ones that you've asked for. I find this is the most useful for, as I said, there's some phenotypes with multiple genes that cause the same phenotype, or a gene that is caused by that results in multiple phenotypes. So this tests for more genes so that you have more likelihood of getting a positive result. Some studies show that, overall, if you're testing patients, you can get a range of about 15 to 25% of a hit rate. So if you're testing patients who have, a broad phenotype. And so gene panels can be really high yields. So, and the younger you test the patients, or sorry, the younger the person is when they develop epilepsy, the higher yield the result is. So, if a patient develops epilepsy before the first year of life, the yield is close to 30%. Whereas the older they get, the more likely they are to have an acquired cause of epilepsy. And so the genetic test results perhaps have a slightly lower yield. Whole exome sequencing in our province, Ontario, and in many provinces in Canada is not ordered by neurologists, it's ordered by medical geneticists. And that's really the exome part, the coding part of the genome, right? So there's so many genes, more than 20,000. And we often recommend this for patients with a very broad phenotype. And often we can do a panel. And in Ontario, if you order a panel of 100 or less, the patient can qualify for a whole exome sooner. You have to wait for 2 years or more if you do more than 100 genes. And the yield of a whole exome tends to be between 20 and 40%. Whole genome sequencing, I can't order that, of course, and it tends to be more available through research, but it has a higher yield, about 42%. So in a neurologist practice, my most common practice is to order in a patient with epilepsy and epilepsy plus, epilepsy and intellectual disability, is to order a CMA, so CGH microarray, plus or minus a karyotype if it hasn't been done, Fragile X testing, if it hasn't been done, and it often has by the time they reach me in the adult world, and an epilepsy gene panel that focuses on the phenotype of the patient. So of course, when we do this, of course, sometimes we get positive results. Yay, you're a superhero, you identified the cause of the person's epilepsy, but sometimes we get these variants of uncertain significance. And the most common question I get is, how on earth do I manage this variant? I don't really know what to do with it. So really, there's a pretty clear pathway that the molecular, the medical geneticists go through to identify whether this is a variant that is causative of disease. And we often go through things like its frequency in the population, what type of variant it is, if it matches the phenotype, obviously, and whether it has a high pathogenicity score on some models of the gene. And then we often can reclassify, we often reassess every 2 years. And I'll work you through a case in just a moment. So the case is not intended to be a challenging one. It's a pretty clear one, in my opinion. So it's a patient who walked into my clinic like this, with this particular gait. A 48-year-old gentleman identified with a vaccine encephalopathy, came in with his mom, had severe ID and epilepsy, had myoclonic jerks and generalized tonic-clonic seizures, although the seizure frequency had diminished significantly in adulthood. But the gait had really declined, and he developed some stiffness and rest tremor. So this is just when I was doing a telemedicine consult, and I just videotaped his gait. He was on those medications, so about Devalproex, levetiracetam, and topiramate, had a normal MRI brain and a normal EEG in childhood that showed generalized spike and wave discharges. So clinically, the phenotype I thought was, Dravet syndrome. So we did epilepsy genetic testing. And of course, a VUS popped up. So I was like, okay. So we kind of worked through it. So when you get these genetic test reports, they'll give you a little bit more information. So for example, like, how frequently was this variant identified in our population databases, what type of variant it was, and so forth. So the first step, though, is it's clinically valid. So a variant was identified in SCN1A, and as most of you know, 80% of variants, pathogenic variants in Dravet syndrome are due to an SCN1A pathogenic variant. So that matched with the phenotype. It was not previously reported in the literature, so that was an X against it being contributory, but we have to identify them before they can be reported, right? So frequency, so in the little like readout that I got with the report, it said that this change was not identified in any databases, so that's more suspicious for it being pathogenic. If you see it reported, say 0.001, that seems like a small amount, but for a small variant, it's actually super common, so you wouldn't think it'd be associated with a severe ID in epilepsy. It's a missense variant, and about 40% of the variants in Dravet are missense variants, so that kind of goes along, or in SCN1A to cause Dravet. And this is an inheritance pattern that's autosomal dominant. So, for example, if I'd identified a variant of uncertain significance in a recessive gene, I'd be like, nah, it's probably not contributing. They have one copy of a recessive gene. That's not relevant. In this case, it's a gene that is known to be passed on in an autosomal dominant or de novo fashion, so it makes sense. The prediction models suggested that it was a deleterious change, so that made sense also. And both parents were tested and neither of them carried this change. Now, that being said, we did not test paternity because the father passed away shortly after, and I wasn't able to get more DNA to do paternity testing. So referred to medical genetics, and it was reclassified as a likely pathogenic variant. And so we were able to counsel the family that, yeah, this is actually Dravet syndrome and not vaccine encephalopathy after all. So when do you reclassify these variants? So usually we recommend reclassifying every 2 years. And most companies who do genetic testing are pretty great at just ringing and saying, hey, this bus was reclassified. It's definitely benign, or it's definitely pathogenic or likely pathogenic. And this study showed that about 30% of patients with a VUS, it can actually be clinically significant. It just takes time to unravel that or to unmask that story. Back in 2022 at the AES, there was a study, they were presenting some data on methylation profiling. So if you look at the methylation pattern in variants, and if it's similar to the methylation profile in a pathogenic variant in the same gene, that increases the likelihood that it is pathogenic. And interestingly, this very quickly has come into clinical practice. I'm already getting reports saying that a methylation pattern suggests that this is a pathogenic variant. So that's kind of a neat, really quick turnaround time in something that was in the lab and now is in clinical practice. So when you do epilepsy genetic testing, how often do you identify actionable findings? And again, this is in adults because I'm an adult neurologist and adult epileptologist. And this study showed that in over 2,000 patients, adult patients with pharmacoresistant epilepsy, about 57% had an actionable change. And that could mean either change in medications, a change in diet therapy, or surgical changes, which I think is really important because many of these patients are worked up for epilepsy surgery. But if you identify a gene where you are thinking maybe this person isn't going to be as good of a candidate, this might change the families and the physicians and the patients' thoughts about surgery. When I talk about precision therapy, in my mind, I have kind of two ways of thinking about it. There's precision therapy that's disease modifying. So you think about supplementation of substrates that are missing. So for example, in patients with pyridoxine deficient epilepsy, if you replace pyridoxine, that's changing or adding something that they're missing. We also talk about gene editing, so with antisense oligonucleotides, and there's emerging, clinical trials, for example, in SCN1A and Angelman syndrome. Angelman syndrome, of course, here locally in Ottawa by Dr. Sell, that can change the underlying disease course as well. And the rapamycin derivatives, I put them in this section too because it changes the underlying structure propensity to epilepsy in more than just an anti-oncogenic manner. And this is a table that I've modified from another publication, but I keep adding to it every now and then, right? So I have to start expanding it to 2 pages. But this is a list of medications that are both for epilepsy and also repurposed medications where we now understand the underlying physiologic mechanisms of certain types of epilepsy, and we've used medications that have been repurposed to modify epilepsy in these cases. And so there's a list here that everybody asks about, and it's interesting to look at them. And we now know, for example, that in Dravet syndrome, of course, everybody is very familiar with this, that medications such as gabapentin and fenfluramine can be very effective in Dravet syndrome, and just knowing that underlying diagnosis and knowing the underlying genetic cause can change how you manage these patients, both in pediatrics and adulthood. Same thing with KCNT1, emerging evidence that in gain of function variants, quinidine can be helpful, and maybe berloprila as well. And there's a whole list. I won't go through them all. You can read that for sure. Okay, so now we know that So epilepsy can be caused by an underlying genetic etiology. We know that genetic testing can change the management of patients, and sometimes we can use precision therapy to modify how we treat patients. So obviously, when I came into practice back in 2014, I was like, I'm going to do genetic testing on all the people, on all the patients. But back then, it wasn't really readily accessible in Canada and in Ontario. So I would have to apply to the Ministry of Health to send, gene panels. And at the time, I was able to do whole exomes, but predominantly gene panels to the States. And it would cost between $1,000 and $8,000 up to 9,000 American dollars. There'd be delays because I'd have to apply and then send the testing off, and it would take a long time. But a group of adult and pediatric neurologists, medical geneticists, genetic counselors, et cetera, got together and advocated to the Ministry of Health that we should repatriate epilepsy genetic testing to Ontario. And in October 2020, the Ministry of Health gave a thumbs up to that. So right now, the testing for gene panels specifically is done in London Health Sciences Centre. So this is the list of genes. We're modifying a little bit, adding genes, taking away genes. So this is an older one. New one's going to be coming out in the next 6 months or so. And we would recommend that patients be tested based on their phenotype and certain criteria. But the ministry, of course, had some questions. It's expensive to test patients for genetic epilepsy. How do we know that the physicians and nurse practitioners ordering these tests are offering the appropriate panels in the right patients? Can we ensure that they're getting appropriate genetic counseling pre and post? And do these tests really affect patient care in real time, in real life? And so we suggested that perhaps the best way to know if this is the case is to offer an educational program. So to teach clinicians, caregivers, how to use these panels and when to use them. And we use the format of the Echo Epilepsy format to teach clinicians how to use this. So Echo Epilepsy Genetics was formed. And so, I was able to get together this crack team. It's almost like an Ocean's 11 of epilepsy genetics. So Dr. Kevin Jones is a pediatric neurologist, Dr. Tuche Balje, and Dr. Dave Diamond are really fantastic geneticists who help us, and then Stacey Houston is a genetic counselor. So we would offer, a brief 10-minute didactic and then discuss a case over the remainder of the hour. And so we invited everyone to join this. And so when I talk to you about the results I'm going to share here, there's kind of two bubbles. So Project Echo Epilepsy Genetics is an educational format that I participate in, and the Ontario Epilepsy Genetics Testing Program is the lab, and they also collected some data. So first I'm going to talk about Project Echo Epilepsy Genetics. So whenever you would order a test, an epilepsy gene panel from the OAGTP, one of the questions that you can tick is, have you taken the Echo Epilepsy curriculum? You don't have to have taken it, but it really helps, and it helps you manage the knowing which tests to order. So we organized this educational session, and I'm telling you the data up until February 2023. It's ongoing right now, and in fact, there's a session going right now that I am missing out on to, of course, give this really important talk. So thank you for that. So we had about 275 attendees, and about a quarter of them completed the survey before and after. Now, if you do any surveys, this is an amazing number. Like, it's actually a really high turnout, as opposed to 2 or 3%, which we can sometimes get. So I'm going to focus on this particular box because we ask these questions about every panel, but I'm going to focus on what we call the comprehensive panel, which was all the genes tested. 70% of the time, that was the test people ordered. So before the genetics echo sessions, only about a quarter of attendees felt they knew enough to order genetic testing, felt they were confident enough to do it, and felt that they actually did it in their practice. In contrast, if you look at post-echo, so post-teaching, 85% felt that they had enough knowledge, 78% felt that they were confident enough to do it, and 63% were going to do it in their practice. Now, of course, that was only a couple of weeks after the session, so I imagine if we do it a year or two later, that number of 63% would only go higher. And that's represented in all the panels. So each panel we would go through and educate people on how to use the panel, and the same data came out for each panel. What was also cool is that it changed the practitioner's idea of how well they could manage their patients and how satisfied they were in managing epilepsy genetic patients. So they found that it helped expand care to their patients. They were able to offer a positive impact on the quality of life of their patients. So that ranged from 75 to 98%. And we asked these individuals, do you think that testing the patient's genetics for epilepsy changed their management? And 68% felt that yes, it changed how they managed that patient. Um, so the echo group testing showed that it changed the management of the patient as per the thoughts of the clinicians taking care of them. Shifting gears. So the OAGTP, which I'm also part of, also collected data and asked questions. So every time you would send off a request for genetic testing and got the results back, you'd have a little questionnaire. And part of the contract was that if you get genetic testing back, that you would be kind enough to answer this questionnaire. And so all these numbers really boil down to, if you look over to the far right, there were 925 patients essentially tested. And so we're looking at the data from those 925 patients tested. So the questions we asked were, was there a change in management? What was that change? Medications, diet, imaging, further referrals? Did you test patient family members and parents? So all these questions were asked. And so we got a 64% response rate. So if you think I was impressed by the 25% from Project Echo, 64% is amazing, right? Now, that being said, we were, the OEGTP was quite, I think, practical in that it was attached to the very back of the result. And so you opened it and you saw this little questionnaire and you could quickly fill it out, right? And so that was really great. 64% response rate. So that's 337 responses. And we found that overall, about 67% of the tests requested were the comprehensive panel, with everything else being asked a little bit less. And we also found that about 19% of the tests identified a pathogenic variant. So if you looked at previous assessments that were done with labs outside of Canada, although some of them were Canadian researchers, it was about the same. So between 15 and 23% yield. So this is consistent with previous data. That tells us we're looking at enough patients and we're not looking at too few or too many patients. So it's a pretty consistent yield. And the next question is, what was the clinical utility? Was there a change in management and what percentage of patients? So we found that about 45% of patients experienced a change in management. And we're still kind of going through the data as to what that change in management exactly was. And that will come out further once we get all the data together and publish the paper. So in conclusion, epilepsy genetic testing is important and it's becoming a mainstream part of our practice. So when we think of epilepsy management, I kind of have a trifecta that I think is important. So obviously all of us think that the neurophysiology is really quite key, right? That's all of our favorite part. And of course, neuroimaging has become quite key. But a third part of that is epilepsy genetics. And although of course I have many colleagues who are fantastic researchers in this area, we're trying to promote this idea that it's part of the mainstream clinical assessment for our patients. And it's important for managing them and for changing clinical care. So again, this highlights the importance of epilepsy genetic testing in daily practice. And just reminding that it can change, up to 45% of the management of patients with epilepsy. There are many people who work on these projects, both Project Echo and then of course the OEGTP. So I'd like to thank all of them, especially a thank you to Dr. Carter Sneed, who really helped fund many epilepsy units in Ontario and help to really advocate to the ministry for increased funding for epilepsy in our province. So I'd like to thank you all for your kind attendance, and thank you again to this Clinical Epilepsy Teaching Network for inviting me today. Much appreciated.